Hey guys, Spencer here, and I'm going to be presenting our second case from Infectious Disease 102, and that's ticks. This is a case of a patient, Aziz, who is worried. For months, he's had a hard time concentrating, and he's had intermittent headaches as well as some low back pain with numbness and burning down his left leg. His left knee has been swollen a couple times off and on, and he doesn't recall having any injury. He lives in LA, but he traveled last summer to Acadia National Park in Maine, and he says that he did see ticks around, but he, took all the recommendations, precautions, never saw one, never had a bite, never had a rash. So, which is true regarding the diagnosis of Lyme disease. Number one, it's rarely diagnosed outside of high-risk areas like Northeast or Upper Midwest. Number two, spinal tap is recommended for all patients complaining of a headache. Number three, diagnosis can be made both clinically and through laboratory testing. Number four, an infectious disease specialist should be consulted to interpret the results of the Lyme antibody Western blot. Number five, Lyme serologic test has a high specificity in patients without likely exposure to Ixodes scapularis ticks. The correct answer is three. Diagnosis can be made both clinically and through laboratory testing. So, today we're going to be talking about Lyme disease and how to make an accurate diagnosis. So, keep in mind that even though Lyme is definitely concentrated in certain areas, and this is sort of a heat map of the incidence of Lyme, I think these are 2015 data, but last couple of years, mostly in the Northeast, Upper Midwest, and Pacific Northwest. There can be Lyme in kind of all over the country, and patients especially travel. So be sure to ask about travel. And the key is that someone's been exposed to a wooded or grassy area, meaning if somebody basically lives in a nursing home or they traveled to Boston, but they were just in a hotel most of the time, that's probably unlikely. It's more about getting out into nature, hiking. Ticks can be in yards, residential yards as well, but someone needs to have exposure to some place that's grassy or wooded. So this is the kind of classic easy diagnosis when you see erythema migrans, especially if there's a tick. This is early Lyme, and you treat this immediately with a 14-day course of doxycycline. You can use amoxicillin or ceftriaxone if someone's allergic or they're a child under 8 years old. They should have one of those, and you're done. Boom, no testing is needed. Patient is cured. But it's not always so simple. So first of all, nymphal ticks can be the size of a poppy seed, so often can be missed. You don't just see them, and they can be in places that are hard to find. So you might not actually have a tick. But if you have erythema migrans, that looks pretty classic, and you have somebody who, again, has that exposure where they could have been exposed to a tick, it's still recommended to just treat them. Now, Aziz didn't have either of those things. He had no tick bite, he had no erythema migrans, but he was in a high-risk area, and now he's having some sort of additional symptoms. So could he have what's called late stage or disseminated Lyme? He's got decreased concentration, intermittent headaches, radiating back pain, and left knee swelling off and on. So let's look more at the symptoms of disseminated Lyme. So keep in mind that Borrelia burgdorferi, like Treponema pallidum, is a spirochete. So just like syphilis, it can have a whole variety of signs and symptoms, and it can have early disease, late disease. So for disseminated Lyme, we're looking at a kind of flu-like picture. So definitely fever. We're talking like 4 or 5 days of fever or longer. Chills, headache, fatigue, muscle aches, joint aches, swollen lymph nodes. So somebody who looks like they have the flu. I mean, they are sick looking. They don't feel good. Skin, multiple erythema migrans lesions over the body. So not just one where the tick bit the person, but a bunch. Neurologically, a classic board question is the bilateral Bell's palsy. Is pretty much pathognomonic or highly specific for Lyme disease. Of course, that's really rare. So most of the time, if it is Bell's palsy, it's unilateral, which has a few other causes as well. But you might be thinking Lyme with that. Severe headaches, serious neck stiffness, so kind of a meningitis picture, or really notable memory or cognitive issues. So again, we're not talking about someone who just feels a little fatigued. Something more specific is usually there. Musculoskeletal system, you get this very swollen joint, often a large joint like a knee, and it's comes and goes, and it can be really swollen out of proportion to the pain. So it's not hugely painful, but there's a lot of swelling there. And lastly, the spirochete can invade the heart and affect the conductive system, and you get heart block, and it can be first through third degree. And patients will often present with palpitations and symptoms around that. So one of the guiding principles here is patients with disseminated Lyme have something notable going on. They're not just kind of fatigued or depressed or mild nonspecific symptoms, they usually have something that makes you think, oh, this could be Lyme. So we're going to look at testing, but we want to remember that, we should have some specific symptoms here if we're going to be thinking about Lyme. So again, let's think about Aziz. He's got some of these: decreased concentration, headaches, he's got radicular back pain, and he's got this left knee swelling, which is pretty suspicious for Lyme. So what do we do now? Well, we really need to decide if he has it or not. So if you're really not sure based on the clinical findings, but there's enough there that you're concerned, then you would want to order a Lyme disease antibodies with reflex to a Western blot. So, and diving that into a little bit more deeply, we can see how that test can be useful if you use one of these pre-test probability, post-test probability charts. So a positive Lyme test has a likelihood ratio of 15. So that's pretty strong, actually. And so if we were to say that we think that Aziz might have it, there's a reasonable chance. So let's say his pre-test probability, for example, we're kind of making it up, but let's say it's 70%. That actually shoots him up to 96%. So that's a pretty big difference. And 96% is pretty much confirmatory that he's got Lyme. We want to treat him. But if he had a negative Lyme test in this setting, then his sort of guess probability is 70% after the test, or pre-test probability is 70%. After the test goes down to 20%. And that's actually pretty meaningful too. I mean, it's a pretty significant drop, and now it becomes more like 1 in 5. So he doesn't likely have Lyme. There's still a chance that he could. So you want to follow him and sort of decide based on ongoing symptoms, or talk about would you want to just treat empirically. But the test can be really useful. But if somebody has a low pre-test probability, like 10%, and you sort of redo these calculations, you'll see that the test, even with a good likelihood ratio of 15 or 0.1 for a negative test, still doesn't really give you definitive answers or information that you can really act on clinically. In this case, because his symptoms are pretty consistent with possible disseminated Lyme, we might want to offer treatment to him. And certainly when patients you think have Lyme, even if you're sent off a test, if you're thinking that they have Lyme, go ahead and treat them, because the earlier you start treatment, the more likely they are to recover. They actually do start to feel better pretty quickly after they start treatment. So that's sometimes helpful. Like if they, the fever breaks and their energy comes back, you're probably doing the right thing for them. The standard course is oxycycline, 100 milligrams BID. 14 to 28 days is the best guidance that we could find in our research. It just seems like experts, some of them pick 14, some of them pick 28. The testing is negative. You can discontinue treatment, especially if the patient isn't feeling any better. That's pretty reasonable, depending on how specific their symptoms are. Again, if they have classic symptoms for Lyme and the testing is negative, you might continue treatment. And then keep this in mind, patients can be symptomatic after treatment for up to 12 months. They may not get fully better, even though the bacteria has been treated and they're cured from the disease, the symptoms don't resolve. So patients do continue to have symptoms for quite some time. And then there are some patients that have ongoing symptoms for much longer that seem to start with the Lyme. And this is somewhat controversial in that no one really knows exactly what's going on. Some people think that it's a autoimmune condition that gets triggered, but they call it like a post-Lyme syndrome, something like that. And it needs to be treated symptomatically or keep looking for other causes, but there really is no good evidence that there's anything called chronic Lyme infection. The antibiotics do treat the Lyme disease. So our take-home points are that Lyme has both early and late stages, which can be recognized clinically. Treat Lyme when you suspect it, even before testing has been completed or without testing if it's a really clear picture. And patients with Lyme usually have something going on, so we shouldn't be testing and treating really nonspecific symptoms. So hopefully that's been helpful. And if you have any questions, just let me know. Thanks.